the clinical co-director of the Center of Excellence at Massachusetts General Hospital, Dr. David Chad.
Good morning. It's really a pleasure to be here. Thank you, Bill, for your introduction. Elizabeth, Gina, and Pat, thank you for, and the whole staff for putting together such a beautiful conference. We're looking forward to seeing you, of course, today and then over the course of the months and years to come at 165 Cambridge. So Elizabeth asked me to kind of set the table, if you will, for the afternoon, and the topic she suggested was the clinical spectrum of Charcot-Marie-Tooth disease. And so I took on the challenge, and we'll proceed first with some basic information about the peripheral nervous system that I think will help to appreciate a little more what happens when there are some difficulties with the peripheral nervous system. So what is CMT? It's a peripheral neuropathy, and it's named for three physicians who first identified it in 1886. Jean-Martin Charcot, Pierre Marie, who was his resident apparently, and Howard Henry Tooth, who was an English neurologist. And here you see a photo of Charcot at the venerable French Institute of Neurological Disease called the Salpêtrière. And Charcot was a very influential figure in neurology, sort of considered in many ways the father of modern neurology, certainly in France, but I think around the world. Not only did he kind of put Charcot-Marie-Tooth disease on the map, but he was very instrumental in defining motor neuron disease, ALS, also multiple sclerosis. And he also had an interest, and this is what you're seeing, the subject of his last interest was the hypnosis for hysteria, which at the time was thought to be a neurological disorder, and later it's recategorized. So he had some major contributions to the field. Next to him is Babinski, who you may remember. You may know of that name. He has a reflex named after him. So what is a peripheral neuropathy? Well, it's a disorder of the peripheral nervous system, and it arises from an alteration in the structure or the function, often both, of individual peripheral nerve fibers. And so I thought we would have a look at the normal peripheral nervous system, and more specifically at its building blocks, that is the nerve fibers themselves. So here you see a scheme of the nervous system, the brain and the spinal cord, which are not affected in Charcot-Marie-Tooth, and then you see the blue nerves issuing from the spinal cord, gathering together in the arm, finally giving rise to the nerves, the median nerve, the ulnar nerve, the radial nerve. And in the leg, again, almost like the branches from the trunk of a tree, the nerves emerge from the spinal cord and form the major nerves of the leg, the sciatic nerve, the femoral nerve. If we just take the sciatic nerve as an example, we know that it contains nerve fibers, motor fibers that are going on to muscles, and sensory fibers that are taking information from the skin back to the nervous system. Oftentimes nerves will branch, and the sciatic nerve is no exception, to give rise to a purely sensory nerve, and those nerves will contain just sensory fibers. So let's imagine for a moment we could peer into the sciatic nerve. So what would you actually see if you could look into the nerve? You'd see that nerve is actually composed of thousands of axons, they're called. Nerve fibers are also known as axons, and I'll define that a little more fully in a moment. These nerve fibers or axons are really tiny, okay? They range from less than a micron to as big as 20 microns. Just to put that in perspective, a human hair is maybe 75 microns. So we're talking pretty small here. And of course, it has to be small if you're going to fit all that critical information into a very small space. And so here is the structure of nerve. Let me just say before I go any further, I love Wikipedia. I think when I retire, I'm just going to sit down with my computer and just scroll through Wikipedia. I mean, it's just fantastic. This is from Wikipedia. I'm sorry I didn't give a fuller acknowledgement. A very nice artist helped me with this. So here you see the nerve in what we call a cross-section. You can see that the nerve is actually made up of fascicles of nerve fibers. If you take one of these fascicles and sort of tease out, if you will, a single nerve fiber, you can see that the individual fiber is made up of an axon, or the core of the nerve fiber, and the nerve fiber is surrounded by this myelin sheath. The myelin is actually made by another player here called the Schwann cell. This is the unit. So this is the individual building block, if you will. This is the substrate of all the action that goes on in the nervous system, in the peripheral nervous system. If we just look a little more closely, and we take one of those sensory nerves, I wanted to do a little spectrum teaching today because Elizabeth wanted me to talk about spectrum. So you actually see that in the nerve, there are a variety of nerve fibers that are kind of along a size spectrum. So if you start out with the largest one, it's called the A alpha fiber. This fiber is the one that's going to be carrying information about touch and pressure and vibration. This is the fiber that's going to be taking signals from your feet up to your brain to tell your brain where your feet are in space. So when you close your eyes, you don't fall over. And you can imagine if you have a problem with these nerve fibers, when you close your eyes, you might topple a little bit because of the compromise in these important fibers. Then there's a somewhat smaller fiber called the A delta that has a thinner myelin sheath. And then there are fibers that we call C fibers. These are fibers that don't have any myelin sheath. And they and the thinly myelinated fibers are very important because they're carrying information about cold or hot or pin. In other words, painful, unpleasant sensations. And for reasons that are not entirely known, although we have good ideas, if you have a problem with these fibers, the smaller ones, then kind of paradoxically, you might feel pain. Even though those pain fibers are compromised, you might actually have feelings of pain. We know that in Charcot-Marie-Tooth, pain may not be a major manifestation, but it certainly is in some patients. And the thought is that maybe the nerve, having been injured a little bit, is trying to heal, and in so doing, becomes rather excitable. Then there's a third fiber type. It's called the sympathetic fiber, and I let you know about that because this is the fiber, also in peripheral nerve, that's going to be important in supplying sweat glands and blood vessels of the skin, and the muscles called piloerector muscles that cause the hairs on your skin to stand on edge. Occasionally, the autonomic nervous system is affected in Charcot-Marie-Tooth. And then if you looked using an electron microscope, if you looked at a cross-section of a healthy nerve, you would just see in more detail, if you will, this heavily myelinated fiber. Here's the axon here, and here's the myelin sheath. This is a fiber that could be conveying information about touch or pressure. And then you have a somewhat smaller fiber right next to it, a somewhat thinner myelin sheath. And then you see here, scattered throughout the nerve, these fibers that are called unmyelinated. They're surrounded by the cytoplasm of the Schwann cell, but the Schwann cell never actually makes myelin around them. They actually make up most of the nerve fibers in a peripheral nerve. And as I said, they're the ones that are carrying information about pain and hot and cold, and they're also the autonomic fibers. And then the last fiber to talk about, obviously very important, is the motor fiber. So we said in the sciatic nerve we have all those sensory fibers, we also have motor fibers. And the motor fiber originates in the spinal cord from what's called a motor neuron. And that motor neuron sends a long tail or axon, myelinated fiber, to the muscle. And when it contacts the muscle, it does a lot of very important things. It not only makes the muscle move, But when the muscle isn't moving, it's releasing signals, chemical signals, signal messenger molecules that are keeping the muscle at a normal bulk, keeping the muscle healthy. So if you have a problem with this motor nerve, not only will the muscle weaken, but the muscle will become smaller in size. So, as I said, just to summarize, the fibers that we saw in that sciatic nerve, just as an example, are functionally distinct. They're dedicated, some to the transmission of sensory information. I've mentioned heat, cold, vibration, pressure, touch. Then there are fibers devoted to transmission of motor information that keep the muscles normal in size and strength, and most importantly, make them move. And so if you again sort of look at a normal nerve, again in cross-section, you see this very harmonious kind of situation. The axon next to the myelin sheath, they're probably doing a whole lot of talking to each other, kind of supporting one another. The axon's staying healthy, the myelin sheath is staying healthy. And if you sort of stretch the nerve out and you look in what we call a longitudinal section, you can see again the axon, blue in the middle, surrounded by the myelin, the yellow so-called compact myelin. And then there's an area, we'll come back to it in a minute, where the myelin ends in a particular segment, and then there's a space, and then this is repeated. You know, there's another axon with its myelin sheath. And that area between two regions of myelinated fiber is known as the node of Ranvier, and I'll come back to that in a minute. It's kind of like the business portion of a peripheral nerve, and I'll explain it in a moment. So now what happens? What happens with CMT? How does that situation I've just described of harmony change? Well, at the root, as you know, of all forms of CMT is a faulty gene. And that faulty gene leads to the formation of a mutated or abnormal protein that in turn causes either an abnormality in myelin or in axonal function. I'm perhaps simplifying it a little bit, and you'll hear from others later that it's a little more complicated than that, but I think it's fair to say that some of the proteins are primarily involved in myelin health and others in axonal health. Although, as I say, it's not a clear distinction. So if you have a protein that's caused a myelin disorder, it's going to cause a change in the way the nerve looks under the microscope. And I'm showing it to you here. If there's a myelin protein abnormality, it's going to ultimately cause thinning of the myelin sheath, that nice, robust sheath around the axon. The nerve actually undergoes some degeneration. And so if you look under the microscope, you just see many fewer myelinated fibers. And if you look under the electron microscope, you see something that you've probably heard about that's a phenomenon called onion bulb formation. The axon and the myelin sheath is still there, but it's thinner than it was in its original state. And surrounding the axon and the myelin sheath are redundant folds of the Schwann cell. What happens is that the nerve tries to heal itself, and it keeps trying to build up more myelin and build up more myelin, but it can't seem to succeed. So the nerve actually becomes very thick. And sometimes in the clinic, you can actually, you will experience, and we can see sometimes, some of the nerves are actually palpably enlarged, so-called nerve hypertrophy. Now, if on the other hand, the problem is a protein related to axon function, the axon will bear the brunt of the injury. And what you see in the biopsy, not that we are doing biopsies on a regular basis at all, please don't be concerned about that. We have other ways. But if you were to look under the microscope, you'd see that there's a reduced number of axons, and the axons are actually trying to heal. They're regenerating. They're trying to repair themselves. And that manifestation of that is something called a cluster. So we see that under the microscope. In either case, whether it's a myelin problem or an axon problem, the structure of the nerve has been altered, and this is going to result in impairment in the function of sensory and motor nerve fibers. And that's going to lead to the emergence of what we know as the clinical picture of Charcot-Marie-Tooth disease. There are variations, of course, but overall, a very slowly progressive condition. It's length dependent. What do we mean by length dependent? We mean by that the symptoms usually, but not always, usually begin in the toes, the feet. The areas affected are those that are supplied by the longest axons. The shorter axons going to the knee, going to the hand, are maybe affected, but much, much later on in the evolution of the disorder. So slowly progressive, length-dependent condition that's affecting motor fibers and sensory fibers, and therefore, because motor fibers are involved, there'll be weakness, and because sensory fibers are involved, there'll be numbness. One thing that we don't see a lot of in Charcot-Marie-Tooth, but there are certainly exceptions, is a lot of what we call positive sensory symptoms, prickling, pain, burning. It happens sometimes, but it's less common than in other neuropathies. And what one sees often, again, but not always, in Charcot-Marie-Tooth disease is some alteration in the anatomy of the foot, known as pes cavus, with a very high arch, sometimes along with what are called hammer-toe deformities. So here's the pes cavus, a very high arch, and the hammer toes. Ken will probably, and Sabrina will probably talk more about that later this afternoon, but probably arises from the unequal forces on the foot, some muscles being sort of stronger than others, and ultimately the foot adopts this particular posture. So now we're meeting our patient in the clinic, and it's very important to take a detailed history, perform the neurological examination, and it's amazing. You go to the Mass General and kinds of high-tech stuff and molecular biology, but look at what we have. This is our toolkit. Dr. Fridman actually has a much fancier tuning fork. She scolded me the other day for hanging on to this relic. But the point is, you're trying to evaluate sensation, light touch with the Q-tips. Pin, we actually have something a little more gentle than a safety pin. We're going to try to elicit reflexes with our reflex hammers. We all have our favorites. I put two here. I like the one that's lying on its side, the so-called queen square hammer. And actually, we use a measuring tape, because we like to keep an eye on muscle bulk over time. Sometimes that's important. So what are the clinical features? Symptoms may have onset in childhood. Individuals first seek medical care between the first and third decade because of increasing ankle weakness, gait difficulty, and often pain related to foot deformities. And again, there are probably so many stories in this room that maybe some approximate this, some are different, so I'm just sort of giving you an overview. You live with this every day, so I just want to give a sense of it. The examination will typically show loss of muscle bulk and weakness. We say anterior and posterior compartments of the leg. What does that mean? The anterior compartment, of course, are the muscles that will lift the foot up. The posterior compartment is the calf, the muscles that will push the foot down. And typically in Charcot-Marie-Tooth, again, exceptions, it's usually the anterior posterior muscles that are affected first, the ones that are lifting the foot up. There is, because of that, and again, you'll hear later from Ken and Sabrina, the patients will have some degree of foot weakness and may have a slapping gait or a foot drop, which we can do a lot for. And then we'll find a length-dependent loss of pinprick and vibration sense because the sensory fibers are involved. And importantly, another feature of neuropathy is that reflexes will be reduced. In the beginning, the ankle reflex is hard to get. As the condition goes on, you may lose ankle reflexes. As the condition goes on, the knee reflexes may be harder to get. Often the arm reflexes are retained, but over time may be lost as well. Again, sometimes that doesn't have any functional consequence. The arms are perfectly strong, but you can't get reflexes. It doesn't mean a whole lot from a functional standpoint. So what one sees in patients, again, overall in general, is what we call a stocking glove pattern of sensory loss. That is the length dependence that I mentioned. The feet first, then the sensory loss may move sort of in a wave up towards the knee, again, over years, even decades, and then possibly the fingers might be affected. Again, a somewhat shorter axon becoming involved. Just to show the hand, sometimes we'll have some atrophy of the what we call the intrinsic hand muscles, but more proximally, very, very rarely. And in the leg, again, that anteroposterior group that lifts the foot up may be weakened, and the foot develops a higher arch, so-called pes cavus change. So now you've examined the patient, and you're fairly certain that the patient has CMT. So what we want to do is a little electrical testing, electrodiagnostic testing. Somebody asked yesterday if we were offering EMGs yesterday afternoon, and Bill said, sure, if you'd like. But there were no takers. But the testing is actually very well tolerated, and we are pretty gentle when we do it. And what we want to do is evaluate peripheral nerve function. Our goal in this test is to determine the speed of nerve conduction, so-called nerve conduction velocity, along a motor nerve. We can look at a lot of different nerves, but the reference point is one of the nerves in the arm called the median nerve. And so based on the velocity, how quickly an impulse goes from point A to point B, based on that number, that velocity, we can divide Charcot-Marie-Tooth into its two broad categories. There are more, of course, but there are two main ones. The ones where myelin's affected, so-called CMT1, and the ones where axons are primarily affected, CMT2. And this all comes back to what I alluded to earlier, the node of Ranvier. Normally, an impulse will travel along the nerve, and it'll actually jump from node of Ranvier to node of Ranvier. This jumping of an impulse is called saltatory conduction. And it jumps along at a really fast rate normally, like 130 miles an hour. That's how fast an impulse will go along a nerve, in a healthy nerve. The reason for that is that at these nodes of Ranvier, there's no myelin. And so a lot of nerve channels are there, channels in the nerve are there. Sodium can go in, potassium can go out, and that generates an electrical charge. And that will travel along the nerve fiber. Now, if you have, and there's your node of Ranvier just in all its glory. I just wanted to show you this important. Ranvier, of course, discovered the node of Ranvier. Again, another icon of French neurology. Some years earlier, Virchow had discovered myelin. But it was the absence of myelin, that is the node of Ranvier, that turned out to be such a critical insight. So what we do, basically, is we put a little electrode over the thumb, and we stimulate the median nerve at the wrist. Then we stimulate the median nerve at the elbow. And when we stimulate at the wrist, we get a response in a few milliseconds. When we stimulate at the elbow, we get a response in a few more milliseconds. Our computer is going to tell us how long it took for the impulse to go from point A to point B. And because we have that measuring tape I told you about, we take it out and we actually measure the distance. So now we have a distance and we have a time. And because we all had to take a little physics before we went into medical school, we know that distance over time is velocity. So we can compute a velocity, and when the velocity is less than 38 meters per second, we're probably dealing with a demyelinating form of Charcot-Marie-Tooth, or CMT1. When it's over 38 meters per second, we're probably dealing with CMT2. So that's a little bit of refinement of the diagnosis that we can do at 165 Cambridge. So now it's likely we have a good idea of the subtype, 1 or 2. And we know, therefore, that, just to summarize, this is a very common inherited neuropathy. It comes in different forms of inheritance. Again, another one of the spectra that Elizabeth, I think, wanted me to comment on, different ways the disease can be inherited. And Dr. Friedman will go over that a little bit more, and Dr. Eichler a little bit more this afternoon. It can be autosomal dominant, where the gene is passed on from parent to child, and each child has a 50% chance of inheriting the gene. It can be inherited in autosomal recessive fashion, where you need 2 doses, 2 genes to have the illness. So neither parent may have it because they just have 1 gene, but a child may inherit a gene from one parent, a gene from the other, and express the disease, whereas the parents are, in a sense, carriers of the disease. And then finally, X-linked recessive, where a mother will have the gene on one of her X chromosomes, but doesn't express the disease because the other X chromosome's gene is unaffected. But she passes her X chromosome on to her son, who only has 1 X chromosome, and he will express the disease. She passes the gene on to her daughter. The daughter will not have the disease because she has an X chromosome from the father that was not affected. You'll hear more about that in a bit. So Its prevalence, I think you all know, it's about 1 in 2,500. Estimated, this is probably an underestimate, 150,000 people in the States, 2.6 million worldwide. That's probably quite a bit under the number. There's the CMT1 form, primarily demyelinating, the type 2 form, primarily axon loss. The 1 form begins in the first or second decade, as we've said. There's involvement of muscles in the legs, to a lesser extent the hands. There's the foot deformity I pointed out, sometimes scoliosis, enlarged nerves in about 1 in 4 patients, and absent reflexes. There's distal sensory loss, as we've said, motor conduction velocity slowing, and the biopsy, if it were done, would show these onion bulbs. And the other form, the CMT2, probably a little less common than CMT1. Symptoms may begin a little later in life, again, just a generalization. Rather similar to CMT2 in all respects, except you don't typically see big hypertrophic nerves, and the nerve conduction velocity is more normal. So we've identified the CMT, determined whether it has a demyelinating or axonal character, and now we want to attempt to use genetic testing to obtain a molecular diagnosis. And a lot of genes involved. You're going to hear about them in just a few moments, and how we go about selecting, the gene to be tested for. And so just to conclude, a common condition, as you well know, we see CMT certainly in our CMT clinic, but we see CMT in our general neurology clinics. It just hasn't been recognized. And we've talked about how it's divided. The clues to the presence of CMT for a non-CMT neurologist would be a neuropathy with some of these foot changes, high arches, hammer toes, tight Achilles tendons. And a molecular diagnosis, the good news is that we can probably make that diagnosis in up to 65% of patients today, and that number is probably going to increase over time. So this is going to be continued with our next speaker, Dr. Friedman, and you'll see why I say hooray in just a minute.
Thank you so much. What a great presentation. Thank you.